we shall start straight away, and I am starting now with this case number 10, sorry. We did number 9 last time, and I think the history was still pigmented lesion in a young patient, around 34-year-old, and then we basically we kind of like dissected the Spitz nevus last time. I'm now going to move on to this lesion, and again, when you look into a specimen, try to stay a little bit in the low power. So this is just to reinforce this technique for the exam. Don't jump to a high power because then you will get confused. So from low power, what you can see that they did a kind of like a punch excision. So if you look into the shape of this specimen, which is quite important in the exam, you also need to be able to identify that is the fact that this is a punch excision, and one things we don't tend to do for malignant lesions, or the surgeons will tend not to do for malignant lesion, is to do only a biopsy, especially when they are dealing with melanoma. They probably can do it for a basal cell carcinoma. They can do it as well for squamous cell carcinoma, for Merkel cell carcinoma, but for a melanoma, they usually a little bit careful, and if they have any level of clinical suspicion, then they might do for you an excisional biopsy. But that's a good clue that you can use for the exam based on the type of specimen, because that will give you some reassurance of what you might be dealing with. Also, yes, there will be an exceptions, but we are talking about exam setting here, and I don't want to drift a lot from the exam setting, okay? So the first thing that you need to highlight is the symmetry, and we talked about this in the last 2 occasions. Now you know that symmetry, if we start with this nest, then we should also end on the other side with a nest rather than a lentiginous proliferation around. So in terms of symmetry, you can say, okay, it looks symmetrical. The other things as well, which is important when you're dealing with a junctional lesion, we don't know yet if this is going to be a junctional lesion or not, but when you look into a junctional melanocytic lesion, just see if this lesion appears to be well circumscribed or not. And what we mean by this, that it is not melting down, where you can sometimes in some lesions, you cannot define where exactly does it end. But if you can make a sharp line to where exactly this lesion is ending, then you can then define the fact that yes, I know where it starts, where it ends, and then you can call it well circumscribed, and this will be also a good clue that you can definitely use. The other things then you will be obviously trying to decide if your lesion appears to be dermal or junctional or compound, basically. But the difficulty, which I do acknowledge for a lot of people, and even I face this difficulty in some cases, is to determine if we definitely have a dermal component or not. And this is quite important because you need to, for example, if you saw some mitosis and in a confluent junctional component, then you need to make sure that this is definitely junctional, because if you are getting it in a dermal component, then, or you are over-interpreting a junctional component as being dermal and you saw mitosis, then you might jump to diagnosis of melanoma. So this is quite important, especially for the Clark's level 1 and 2, this is when the problems happen. Of course, when you reach into Clark's level 3, when you go below this area here, below the superficial vascular plexus into mid-derms, then you will be fine, but usually the problems happen here. So there are two things that I do find a little bit confusing for people. The first thing is that you need to define the fact, where is your adnexal structure, okay? Because if you have hair follicles here, and you probably have another one here, and there are nests that are surrounding it, then that will be, by definition, the levels of where your junctional nests are going to be. So this is a good place to work on. But the other things as well that I want you to pay attention for, that usually what happens in most of the malignant lesions, either if it is arising from a Lentigo maligna, like what we said, Lentigo maligna melanoma, or if it is arising like a superficial spreading melanoma, what happens to the dermal component, it tends to change character, okay? But what will happen here, that but for benign lesions, most likely the cells inside the nest will be the same cells that you get in the dermal component. So this is another things to pay attention to. Of course, at low power magnification, you can obviously notice straight away that there are some retraction artifacts in this particular lesion, and they are quite confluent. So this is also a clue, because as we discussed last time, you probably, okay, then I have now spits in my differential diagnosis, which is fair enough, that's absolutely fine. The things is what you will realize in this lesion, that yes, the cells appears to be in the spindled or epithelioid. Look into those. Okay, so this is another features of these cells. We said that the cells usually so but second please.
इधर रख दो, मुझे चाहिए होगी फिर मैं नहीं मिलेगी, आप बाकी देख लो.
I'm sorry, yes, we carry on. So we have some epithelioid or spindle cells, and what you can then see and create the entire worries and the panic during the exam is areas like this. These are very confluent melanocetic proliferation, and you can see the areas are very confluent here. The cells, like the example from last week, the SPET cells tends to be very aggressive looking in a big way. So you can see there is a little bit of prominent nucleoli among these cells. But one thing is that we still have the directions, the rain-like, or as some of you guys said last time, banana-like. Okay, that's absolutely fine. But one other thing here that differentiate this lesion a little bit from SPETs is the location of the nest. Yes, we have the SPETs nest, like the one that are filling the papillary derms, but you look here across this area here, you start to get adjacent nests as well to the adnexa, and you are getting nests everywhere now. Look, the spread out of the nest is quite diffuse. Look here again, and there it is where the nest is. This is now here, this nest is far away from the papillary dermis itself. This is taking a corner of the papillary dermis. Here, the proliferation has nothing to do with the papillary dermis, and here it is maybe papillary dermis again. Okay, but the distribution of the nests are a little bit different, and the cells for this particular lesion, people tend to say that the cells looks more spindly, especially when they start to bridge between the nest. And as you can see as well, which is a quite unique phenomena that tends to mimic exactly what happens in cancer, is the fact that the bridging of melanocytes, which happen between the junctional nest, can spread out through more than 3 or 4 nests. And this is an important features in malignancy, but this is why the people tend to bring this case for the exam, okay? Because once you see this bridging, you probably will consider architectural atypia. You go to high power, like nucleus like this or this, and you find out that these cells looks atypical, and then you say, okay, I'm happy, I'm going to call this melanoma, or at least in situ melanoma. Then, okay, fine. If you haven't seen or you're not used to this lesion, then you probably will lose the case. One other thing that does characterize this lesion is this heavy pigmentation that tends to be mainly in the higher layers. So you can see higher up around the nest, you tend to get the very heavy pigmentation, and it fades a little bit down as we go down into the nest. And then you have a lot of melanophages here, full of melanin pigment as well in the superficial derms. So all of these are melanophages here. So these are things which you will use to characterize this lesion. This lesion don't tend to have caminobodies like the one that you see in spits. This is basically, as you probably all know, the very famous case, which is the spindle cell nevus of Reed, that tends to come a lot in the exam. So it looks like spits, but with some minor difference, you will be able to know it isn't. There are rare variants of spits which are purely junctional, but majority of the spits nevi are compound, or you can get, of course, the intradermal spits, which is like endesmoplastic spits and those other subtypes. But we are talking about the exams. So if they are to bring the spits in the exam, probably they will bring you the compound spits, because this is very common to find, and then they can get you cuts and put it for exams. But one of the things here about this spindle cell nevus of Reed, yes, it can be compound, but you can see the bridging here. It's reaching the base of the nest. Of course, bridging is not a phenomena that you tend to see in a dermal component. It is a feature that's very, very specific for the junctional component. So this is one thing that to highlight here. But the other things as well is so is the pigmentations, this wide bridging, as I told you, between 3 or 4 nests together, trying to fuse together. So all of these are features that you can characterize it as a spindle cell nevus of Reed. Now, if you are under the stress of the exam and you don't know, oh, I am panicking, I don't know, then just call it spindle cell nevus, because under the group of benign spindle cell nevi will come the spits and will come the spindle cell nevus of Reed. The problem, obviously, that if you cannot name it as spindle cell nevus of Reed, then you cannot give us the brownie point, the clinical informations. You see, so what I tend to, then if I am wanted to score more for a case like this, maybe the maximum score that the examiner will allow you for a case like this is 3. And this is an important point, again, back to when I first talk about how we score, I told you there will be cases where you cannot score more than 2.5 or 3, even if you wrote 5 pages worth of answers. What is important that as we practice and as you do mocks to recognize which cases are these. So, for example, I told you granular cell tumor will be probably one of these cases where you cannot write anymore, and therefore, no matter how you try to write anything about it, you probably will still score 2.5. The same things apply, for example, if you're getting a squamous cell carcinoma in the exam. You know, these are cases, although you are very happy that you got a squamous cell carcinoma and you knew the diagnosis because it's an easy case, but the downside of this, that you cannot score more than 2.5, which basically put a lot of pressure on the other cases. Now, because as I told you, if you got all your answers correct, except one, and you're scoring 2.5 in all of them, except that one, then you fail because you don't get the 50 mark for pass mark for the short surgical, for example. It's an odd scenario and odd situations, but just be aware. So probably this case, if you are to score, you might then score, you might say, then in the differential, so you put your diagnosis as a spindle cell nevus of Reed, and then you put the differential diagnosis, I have considered melanoma in situ. However, this is unlikely because I did not see a pagetoid spread into a higher layer of the epidermis. I did not see abnormal mitotic activity or frequent mitotic activity, and there is no, for example, invasive dermal component. You can put this in between brackets. What I am trying to tell you that you need to spell out these informations on the paper. The examiner will not know how did you exclude the fact that first the examiner want to know, did you consider melanoma? And if you would have considered melanoma, then how did you get rid of it? So you need to tell the examiner, I excluded this because. So you can write that in the differential diagnosis section. And when we come to the additional work, as I said, additional work might include levels, immunohistochemistry, might include special stains, you see, so all of those things you might include it, but here in this case, you don't really need immuno, you don't need anything, and therefore you can then write non-contributory. But again, you need to tell me that you thought about additional work, and this is the way that I would write it in the exam. I will say additional work and non-contributory. And then for further work, for additional information, then section to be able to score points. So I told you this is a 34-year-old, so you can then link this. So you'd say this lesion usually present in a young adult, and the age which has been given does match this. So now you have done your clinical pathological correlation here, which is great, okay? Number 2 is you can also say, if you think that this lesion is completely excised, which we think it is here, then you say this lesion is now completely excised, and therefore this is the treatment of choice, and probably no follow-up is needed. So you can also write that. You know, in our reports as pathologists, we always give a recommendation if we need to do any further excision or not, and a wider excision. So why not to mention it for the exam? you can, okay? And if you are extremely dedicated to melanocytic lesion, these spindle cell lesions can come under a heading of some mutations. So if you can remember the mutation, just put it. I cannot remember it on top of my head now. But what I know that my Spitz and spindle cell nevus of Reed and all of them, if there are some mutations which can be done for those. But that's not important, because as I told you, you probably will be scoring 3 and that's it. And this will take us to another areas which I promised you from last time that we will be seeing a few more cases this time. So let me just show you another areas which you can also, you need to understand it well. So if it is to pop up in the exam, then you are able to highlight it in a better way and more confident way. So here, for example, what we have is a pigmented lesion. So this is now out of this group of slides that I have shown you. And this, for those who just joined us for the first time, we had the permission from University of Leeds to use the website for this teaching because it's a non-profit and we organize it for free. So we had an official permission to do that. So now this is a pigmented lesion, let's say middle-aged 50-year-old. So it's a very, the age is very, it's very suspicious for melanoma. If you actually look into the ideal age for melanoma, it is the 50-year-old. This is when majority of people will be getting melanoma. It's a pigmented lesion, as given in the history, and as I said, stay a little bit at low power and try to understand a little bit of this. So now this I will accelerate a little bit because I will need to review around, as you can see in the top here, we have like 10 cases that I need to review, and then let's hope we will be able to see all of them. So is the lesion which I wanted to show you, and you can see that this was presented as pigmented lesion. The first thing is that we look into the epidermis, the normal epidermis, and you can see the reety shape. So whenever you deal with a melanocytic lesion, do this number 1, okay? Number 1 things, go to the normal epidermis and see what is the normal thickness and what are the reety configuration. And as you move into the lesion, then you can start seeing that the reety ridges here are quite uniformly elongated all over the place, okay? So you can see that quite clearly, that these reety here are much different from the one over there. So the contrast here is completely different. Look at the reety here on this side of the screen. Let me just put the spotlight here. So you can see the reety ridges here are completely different in shape from these very, very elongated reety ridges which are going there. What you also see that the epidermis here start to become a little bit thinned out, you know, in between the elongated reeties, which is not really the normal thickness of the epidermis. One thing that the normal nevi don't do, they should not produce this phenomena, okay? And then subsequently, I spoke about the next step is to judge for the symmetry. So if you start with the nests here at the tip of the reety, then ideally when you go to the other side of the lesion, you should see the same thing. So we have a nest at the tip of the rete. So this is also telling us that there are some kind of symmetry in a way. But we start then in the last 10 minutes, I was talking about the architectural atypia, which I will summarize again. The first one is the elongated rete ridges that are quite uniformly elongated. But this uniformity, we tend to see more with the mild and moderately dysplastic nevi. In severe dysplastic nevi, in the severely dysplastic ones, and in the melanoma in situ, this phenomena does not tend to persist. So it will be lost focally or centrally in the lesion. You might find it at the peripheral of the periphery, but you tend to lose it a little bit. But this is one thing to highlight. The second thing is about the bridging, which is everyone knows that the fusion, the bridge between the adjacent nest, this nest here is trying to be kissing into this nest. But you also have some nests here in this region, a little bit joining up with this one. This is like a fusion rather than a bridge. If you want to see a proper bridge, I'll just put it in the middle of the screen here. This is a nest here and another nest here, and you can see the melanocyte bridge in between the melanocytes. Why I am saying it is because it is quite important. It is quite important to understand that the difference between the fusion between nests or the bridging, okay? Because if it is a fusion, then you tend to have a little bit of a higher grade of classification. So this is another format of architectural atypia. The other point that I also talked about is the variation in size of the nests. And if you if I just show you here that you cannot judge this phenomena between peripheral and a central nest because classically speaking, in most of melanocytic lesion and benign lesion nevi as well, you have a larger nest centrally and a smaller nest peripherally. But here, even when we are staying in the center of the lesion, you can see very large nests here, and you can see smaller nests here and another smaller one there. This variation in size of these nests is a feature, a very important feature for the architectural atypia. The other things is, which also come under the heading of architectural atypia is where the nests are. If you are very clever in benign nevi, they will almost always tell you that the nest usually will form at the tip of the rete ridges. But when the nevus become, when the nevus becomes dysplastic, then you can see that the nest will form anywhere. So this is not really at the tip here. These nests are not at the tip, they are distributed throughout. And now, you also, I appreciate that the fact that it is basically a variable size and shape as well. So these are all architectural atypia that you can add into the equation. And then shouldering. Of course, if you have a dermal component, people like to see in the dysplastic nevi, the junctional component extending beyond the dermal component, which is the case here. And this is also comes under the heading of architectural atypia. So this is for architectural atypia, which is fair, and it can direct you to then say that this is dysplastic nevus, but what it doesn't give you, it doesn't give you the severity or the grades of this nevus. And in reality, the mild and moderate will be treated the same with like 2 millimeter clearance. Severely dysplastic, we wanted like 5 millimeter clearance. And the in situ melanoma and the invasive melanoma, we wanted the 1 centimeter clearance. And some institutes will go even for 2 centimeter clearance. But that's not important, but what it is that it is what the grades now. How we grade this? If you really go through the very clever books and papers, they will tell you to grade this melanoma, you need to grade atypia. But this is important because pathological atypia here is a random. And then if you don't see melanocytic lesion every day in your practice, then when you come to the exam, all the cells will look typical for you. But let me just highlight it for those who don't see melanocytic lesion regularly. How can you detect the atypia in dysplastic nevus? The things what you can do or you need to do is to stay a little bit at a medium power or low power. That's number 1. Number 2, you are targeting the hyperchromatic cells. These hyperchromatic cells might be present inside a nest or might be present very sporadically in between the nests, in the melanocytic proliferations between the nests. So, and the fact is that you need them to spot these hyperchromatic cells, and then you go down directly to them and try to assess them a little bit more. Things like this, things like this guy here. And what you are assessing the cells, you are assessing to see if there is any increase of NC ratio. Just 1 second. Yeah. What you need to assess here is this atypia. Look, these cells does stand out. All of those I am not bothered about. All these melanocytes over there, I'm not bothered about. All what I am bothered about is this guy here. Guys, may I just ask you all to turn your video recording off, please? Because I don't know, some of your videos are on. Yes, so just turn your videos, not recording, I mean videos, computer. Thank you. So you can see, you can spot it. You see, if you are to ask me if this is a typical no, if this is a typical no, look, the NC ratio is not really here the maximum, but you need to have these very hyperchromatic cells are the ones that I will stop by, and those are the ones that I will judge. And if you cannot feel that these are showing, then you need to train yourself. Is it mild, like just a very, very slightly atypical? Is it moderate, like in between? Or is it definitely like looking like a cancer cells? And then according to this, together you build it with, you say it's mild, moderate, or severe. But the key is that the fact that this is going to be a, this is going to be a random atypia. So that is the real things to focus on. And therefore, then you say this is let's say in this example here, which you can see on the screen, this is a 5 millimeter, this is the moderately dysplastic nevus. So if you put it mild to moderate in the exam, that's absolutely fine. You are allowed sometimes to have that flexibility. So for example, a lot of people, when they get the follicular lymphoma in the exam, they prefer to put it grade 1/2 because you might overcount or undercount the blast cells. So therefore, sometimes it's safer to do it that way. And in actual fact, what the people have said you know, like even WHO for follicular lymphoma, for example, you can make it, usually grade 1/2 is acceptable by the WHO, even in the eyes of the expert. So the same here. Now, one thing, we need to see more severe or more complexity in the architecture and more atypia in order to judge something as severely dysplastic. But I just wanted to show you as many cases as I can, and then we will move and see. I will move to another case. Did the screen change now? Good. Okay, so we are on the right track now. So this is again another pigmented lesion, and you go directly to try to assess the symmetry, and you can see that we are going all the way. You can see sometimes it's really difficult and tricky. And look here, we have some nests, and then I go again at, we stay a little bit at low power. This is the normal shape of your epidermis. And look here, we're getting this irregularity, but there is no that uniformity that we saw in the previous example, which we thought it looks like more like psoriasiform. There are areas which are, yes, uniformly elongated, but look here, there are areas which are very irregular in terms of these rete ridges or elongations. So automatically speaking, I know that I am at the dysplastic areas or higher. Okay, so now I know that this is for sure. So this is one thing to highlight here, that you can use this as a clue, and it is very, very, very useful, and it is very easy. And then the second thing is that we still at the symmetry. We just stopped at the center, and look. This now a good example, because this is not showing, this is showing melanocytes that just only scattered, but these are not nests. And this is a good example now to highlight this asymmetry, because I showed you that the other side did show you nest, but this side didn't show you nest at the beginning or the start of the lesion. Okay, so this was a very good clue to highlight into this. The other things, then we go for the architectural atypia, and we apply the same rules. Yes, we have bridging, but we have something more now, okay? Into this view, you can see that these are nests, and another nest here. These are collision of nests. You know, these are like the Star Wars collisions of planets and things. You know, they are trying now to become one, and this is a phenomena that you don't tend to see it at that grade everywhere. In the moderate dysplastic nevi, you might see between two adjacent nests only, like in the previous example, that you feel that they are trying to collide together. But here, you started to see them between maybe 3 rete. So that will give us the fact that these were supposed to be 3 nests, and they are fusing. They are trying to become a one nest. And this is a very, very significant architectural atypia feature that we see in melanocetic lesion. And when I see this, for me, this is going to be either severely dysplastic, or it is going now to be a melanoma. So remember, we saw a very similar feature to this in the spindle cell nevus of Reed at the beginning of this talk. But I told what it is important to remember, there is no attraction artifacts here. but with a caveat, and I will remind you of that caveat in a few minutes. The other things as well, that you can see the nests are very disordered. They are not trying to fill the papillary dermis. You can see most of the papillary dermis in this here is clear, so that should not be confusing with the spindle cell nevus of Reed for you, although it is pigmented, but this is not uniformly pigmented. It is mainly showing this very high pigmentation where the confluent areas are, but elsewhere it isn't. So we're still in the junctional component. And then variable size nest, variable shapes, variable locations, all of those things, as we discussed in the previous example, you can apply here and it will work. And then you start to judge the individual scattered atypia. Is it random or is it more obvious and more scattered? Obviously, I cannot go on a higher power here because this is not very well scanned slide. As you all can see, it is very fuzzy for me as well as for you. But again, in this scenario, when we are between the severe and the melanoma in situ, the definition will become vague between do we really see the random atypia or not. But one thing is to can help us to differentiate is the pagetoid spread. Do you think? Well, for those who think yes, pagetoid spread will definitely help us. I think you probably wrong if you take the first half of the sentence, because in severely dysplastic nevi, it is like spitz nevus in a way. You are allowed to have a pagetoid spread in the lower half of, or the lower 1/3 of your epidermis, but you are only allowed that in the center of the lesion. So if you start to see pagetoid spread higher up, then it's probably not. But another very important clue that I tend to use as well is when I come to look into an areas like here, you have a very confluent nevi into these reedy ridges and some atypia, but look in between, the keratinocytes are still normal. Look, the melanocyte proliferation is focally lentiginous, but look here, again, it did cut. The melanocytes are on either sides, but in between here, there is no melanocyte proliferation. And in the center of the lesion, in a melanoma, this should not be the case, because in melanoma, you usually have a lentiginous proliferation in the center of the lesion. Obviously, toward the periphery, if the nevus is arising on a pre-existing dysplastic nevus, then you will lose this phenomenon. But this is also an important thing. So if I am to summarize how I will differentiate between a severely dysplastic or a radial growth freeze melanoma or melanoma in situ, the first thing is I will go by is the size, because if I am getting a 13 or 14 millimeter lesion, I probably will be a little bit careful to call it dysplastic, because dysplastic nevi, majority of them tends to be 6 millimeter and below. And if they are really big, they go up to 10 millimeter, but they don't go to 15 millimeter or 20 millimeter size lesion. This is, by definition, as soon as the surgeons see a big melanocytic lesion with abnormal staining pattern or pigmentation, clinically, basically, they will call it melanoma, and they do not hesitate. The symmetry, which we discussed, can be lost in both, although in some dysplastic nevi, as well as severely dysplastic, it can be preserved, while in the melanoma, it has to be lost. So this is another thing. The other things, as I told you, to pay attention to the reedy ridges, because in melanoma, And in severely dysplastic melanocytic lesion, what tends to happen when you can see here, you are probably moving in the field from what appears to be moderately dysplastic to severely dysplastic lesion between the two regions, because you have the uniform elongation of the VT ridges, and then you're losing them. But also what tends to happen in melanoma when it develops, it produces some phenomena that we tend to call epidermal consumption, which is basically the lesion becomes the lesion's trying to eat the epidermis, and therefore you don't tend to get a lot of epidermis on top of the melanocyte. So you sometimes count the layers and you find 1 or 2 layers in the areas of the epidermis. And this is a phenomena that we call epidermal consumption. And this phenomena is linked more to melanoma. We talked about the discontinuity of the junctional proliferation and the importance for this to be continuous when we are dealing with the melanoma. The other things as well, which I wanted to highlight, is the collision of the nest. I told you it's a severely dysplastic, but it's almost always there in melanoma. So in melanoma, you tend to have these collision nests very, very present. Pagetoid spread to the higher layer, and the atypia, instead of being random, now the atypia will become more frequent. One thing is that junctional mitosis can be present in severely dysplastic nevi, but usually you find 1 or 2. If you started to see too many of it, then you're probably dealing with a melanoma in a shape or form. But one other difference as well, which I find useful, is when you are dealing with a dysplastic nevus, the inflammatory response tends to be more perivascular, as you can see all across the board here. So you can see there is a perivascular inflammation, but when you deal with melanoma, you tend to have it's a little bit more diffuse, a little bit more looking like a lichenoid in a way. And this is an important difference that can catch your eyes as well. So we talked about looking into the normal epidermis because it can give you a clue, but also look into the pattern of the inflammatory infiltrate because that can also give you a clue. I'm sure that some of you are dying to tell me, what about lamellar fibroplasia? Look, this lamellar fibroplasia, this eosinophilic thickening of the fibers that's trying to highlight the VT ridges. Yeah, it's a very popular term, but most of the lentiginous nervi will also have it. I mention it in a report. Yes, I saw lamellar fibroplasia, but I don't tend to use it as one of the features which will help me for sure to say if this is a dysplastic nevus or not. And I wanted now to move you to another case, which is this case here. Basically what I wanted to show you in that case, you look into this, the low power, again, the VT ridges shape, okay? So this is our normal epidermis. I will go to the epidermis in the middle, and you can see that the VT here has changed its shape. But this is not the uniform elongation that we see in mild or moderate. This is maybe a little bit here, but this is not uniform anymore. And therefore, this is very irregular VT. Okay, so that is one thing to highlight. But while we are in low power, and because we just discussed these points a minute ago, look at the inflammatory response. this inflammatory response cannot be present with a benign lesion. And automatically speaking in the exam, if you are to see this, then you know that you are in the category of being a malignant. So this is or severely dysplastic, but even the inflammatory response here telling me that, okay, can it be then the radial growth phase of melanoma? And yes, there are some pagetoid spread going up here and there, and then, but you might argue and say, well, but it's not going all the way up to the top layers, but it is going a little bit widespread. You can see there is pagetoid here, and there are here in the center, and they are here. So remember, when I told you a minute ago, the pagetoid spread in severely dysplastic nevi should only be present in the lower half or the lower 1/3, but mainly in the center of the lesion. Here in this example, you can see that's not the case. The other things as well, this is now, I told you the phenomena of the irregular shape and size of the nests as well, which is quite confluent here. One other thing is the pagetoid spread when it happens in the uniform of nests. If the pagetoid spread is happening in the form of a nest, the nest is trying to come up, then most likely you'll be dealing with a melanoma. Because in severely dysplastic nevi or in Spitz nevi, the pagetoid spread will not be in the form of a nest. It will only be in the form of individual cells. One thing about the superficial spreading melanoma, which is basically this will be melanoma in situ here rising in the background of severely dysplastic nevus. I know that because when I go to the periphery, I can see that this is a severely dysplastic nevus rather than a melanoma. The melanoma started to develop more from this area here onwards toward the center. But one thing is that this can be, yes, if you want, some people will call this melanoma in situ, in between brackets, the superficial spreading melanoma. That is okay. And the people or the expert will always tell you that if you wanted to know the superficial spreading melanoma, then even without looking, you start to see the pagetoid spread. Okay, so once you reach that phenomena that you can see pagetoid spread without even looking for it, then you are probably dealing with this, what you call it, the superficial spreading melanoma. I told you in the exam setting that's not important, because what's important is to realize that this is melanoma, yes or no, and then you apply the data set items to score the maximum points, and then you advise for all the 8 points that we mentioned last time to score more points. So all of those you have to, you need to spend only 2 minutes with the slides, which we are spending a longer duration with. One other thing I wanted to show you, and I will show you some examples now of, in the next 5 minutes, I will extend the session by 5 or 10 minutes because of the glitch of what has happened, to compensate for you, and my apology for this. Now, what you can see, you can sometimes get these retraction artifacts in melanoma, but this is not a consistent thing. And it doesn't, sometimes you can see it toward the bottoms of the lesions, the bottom of the nest, side of the nest. It's not necessary that it will be toward the apical part of the nest like what we see in some other examples. If, for example, I put this example here, this is another example of a spindle cell nevus of Reed, and you can see the retraction artifacts around these areas and around these areas here again and here. One thing I probably have skipped in the first nevus was the dermal component, and you all know a lot about dermal component, which is the fact that the nests are usually smaller than the one in the junction, the fact that the cells are maturing, or the nests are maturing. And I remember we discussed in one session, and I promised you that I will show you that phenomena. And then I want you to use some imagination here. You know, this will help you a lot. You see that the nest, usually the smaller cells inside the nest, like that one, will be lying inside the smaller cells are maturing. The nests have got larger cells toward the periphery, and as they mature toward the center of the nest, the cells become darker and smaller. So this darker and smaller rule can be applied as well when you look at the individual nests, and then you start to see it. It's just a matter of getting your eyes used to it. Ideally, or classically speaking, another feature of maturation of nest in the dermal component is to have a bigger nest in the higher up, and as you go down, the nest should be getting smaller. Again, it depends on the cut, and sometimes you might need to make sure that you have a lot of levels to identify these phenomena, but it doesn't stop you from in this plastic nevi, then this will be variation. We said that there is a variation in the junction. Here as well, you will start getting some variation in the nests, but it is purely related to the lack of maturation. I showed you some maturation within individual nests here. So the other things is the maturation of individual cells, the fact that if you start getting sporadic cells that are atypical, then you will be in the territory of this melanoma. A lot of it, all the nest has to have atypical cells, a lot of mitotic activity, or even a few, or even one or two that are deep in the surface or deep in the dermis. All of those will help us in identifying that if the dermal component is malignant or not. But your real worry and your real guide for 99% of melanocetic lesion will be in the junctional component. If you have a purely benign junctional component and you are trying to tell me that the dermal component is malignant, but the junctional component is not, then just think again, because should not be the case. So this is another things. This is the case which I also promised that I will show from last time, which is when the spits tend to become malignant, how this will become looking like. So let's see the nevus in general. Spits can be large, but in general speaking, you see that this nevus is quite large. Even at low power here, you can see that there are a lot of filling of papillary dermis with junctional nests, which is a phenomena that we link more to the spindle cell group. Okay? And then even at low power, you are able to see that there are retraction artifacts, as we saw, and here another one, and here again another one. So we know that there are some spitzoid features into this nevus. So that's to start with. I told you spits a minute, in the beginning of this lecture today. Majority of the spits will be compound, and this is a compound nevus, yes, okay? But then we need to start looking into the other phenomena of what is happening really. And what it is, this this is a nested pagetoid. We don't accept this, okay? So this is one thing that I will not accept. Look, there is no lentiginous proliferation. The nevus, the spitz nevus is still looking very much benign, but we start to get a lot of other irregularity of the nests in between. Again, irregular shape, irregular sizes, and this is again not a feature that you commonly would see in the benign spitz nevi. So these are things to remember. The nest, when it becomes malignant, the nevus, when it becomes malignant, it starts to acquire a lot of hyperkeratosis on the surface. Majority of melanocytic lesions, when they are benign, they don't have that. But when they turn malignant, they tend to acquire this hyperkeratosis, which you can see it on the surface. So this is also can give you another clue for this. Again, in pagetoid, in spitz nevus, the pagetoid spread should be only central and not going peripheral. And if you start to see a more peripheral pagetoid spread, I'm just going to the far corner here. You can see there are pagetoid spread here. Look, so this is basically at the periphery of the lesion, and that will also tell you that I am abnormal or I am atypical. What I am not going to search for your time for mitotic activity, but you will start getting a very frequent mitotic activity in the junctional component here. There's one here. Basically, which is not a feature that we tend to see it in the benign spitz. So again, this also give us a clue that we are in the atypical spitz or in the spitzoid melanoma category. The distinction between the two terminology is not important for the FRCPath. If you think it's atypical or spitzoid melanoma, put the two comments next to each other. Mitosis in the dermal component is important, but it is important only when it is in the lower 1/3. So if you are getting any mitosis in the upper 1/3 of your lesion or in the nest, I will tend to ignore those. It is only in the lower 1/3. You remember, for those who listened to the lecture last time, we said that as you go down, the collagen will start to separating more. But what I wanted you to highlight is to come to areas like here, where it's at the deep part of the lesion, and the nests are still trying to become very adherent to each other, and they are very confluent growth. And this is the area where if you start to see a significant cytological atypia, then you worry. If you start to see this, which are individual cells that are coming out of these nests, then you also worry, because this phenomena doesn't happen. But if of a very paramount importance, when you judge the atypia in the spitz nevi, if you remember, I kept going on and on and on last time about drawing that straight line from right to left. But you can see here, if you try to line that straight line for the dermal component, you can see that you are going all over the place. Look, okay? So if you imagine the line with the dots, it is very irregular. It's not ending at one level. And that's by definition telling you that this nevus is not maturing, okay? And therefore, and it's very irregular. So these are the features which I will rely on when I wanted, or I'm faced with a spitz nevus, either in real life or in exam. I apply all these rules, and they should all be working fine. This is just an example of adjunctional spits, just to know and to let you know that this does exist, but you can here see that you will be able to see the clefting artifacts very prominent. But what I wanted to show you, which is more important, is this slide here, which is another melanoma. Okay, and I wanted you to pay attention to a very important phenomena that doesn't tend to happen in spits. But you need to search for that phenomenon in order to find it. So let me just find it first. I think I did find it in the examples when I was searching earlier, and it was nice. Here it is. See this phenomena here? These are you at low power. If I stay at low power, you might say, okay, we have what looks like this nested filling papillary derms. Looks a little bit juicy epithelioid. Okay, you can always say that, but look here what it is. This retraction artifact can tell you, okay, I'm spits, but look, the cells are discohesive. And the discohesion, this is like acantholysis in a way, you know? The cells are not staying together anymore. They're becoming discohesive, and this is a phenomena that you only see it in melanoma. So if you see a retraction artifact around this nested, that's just search for this. Try to find the one or two that has got this discohesion, because that automatically will tell you, I am a melanoma. The nested going up nearly into the stratum corneum, as you can see here, this is also another pathognomonic features for melanoma. The nest can be formed of 2 or 3 cells, or can be 5 or 6 cells. It is only the fact that you recognize it and you recognize where it is. You can see here in this example of superficial spreading melanoma, I do not need to see any of the, I can see the pagetoid spread scattered throughout. You can see that these are more for those who wanted always to know the difference between the Lentigo malignant melanoma and superficial spreading. The Lentigo malignant melanoma, you need to search for the pagetoid spread. In superficial spreading, it's very easy to find. In superficial spreading melanoma, it tends to be more confluent over nests of irregular shape, sizes, and they are coalescing together. You can see those two nests are just becoming one here. Those group of nests, maybe 5 or 6 of them becoming one. This phenomena is not there. You get a few nests, yes, in the Lentigo malignant melanoma, but not that confluent. The cells, we talked about the cells before, and what I wanted to tell you, that yes, these cells are melanocytes with a vacuolated or reticulated cytoplasm, but you can see these phenomena that we stressed on the retraction artifact, or the lacunae shape of the cells, that you see it from one cell to the next one, to the third one. This is not the features here, okay? So the features, the type of the cells is different. They tend to describe more of epithelioid or spindly in the superficial spreading, which it is. And this is why people tend to try to bring this either superficial spreading, like this one, like this example, because people can mix this with the spits because of the retraction artifact. You can see it here, okay? And if this all what you know about spits is retraction artifacts, which I'll be very disappointed now if that's all what you know about it, but if that's all what you know, then you will get it wrong. But now you know that this is not going to be the case. And again, even without thinking, look at the inflammatory cell infiltrate. The inflammatory cell infiltrate alone telling you, I am what I am. Yes, some people might say Halo nevus can have the same, but this is not for exam. Okay, in the exam, I do not think from my memory that in the last 10 years, Halo nevus ever came. So please, if you see this inflammatory cell infiltrate, and they are not telling you Halo nevus in the question, then consider this melanoma till proven otherwise. So this is another one, and I will just close, I think, with this example here, which is another beautiful example of what do you think? I will just put it for the floor now, and you tell me, do you think that this is a benign, or do you think it is malignant? Any taker? Anyone? Malignant, yes, okay. Yes, I agree, malignant. And what you can see that there is a pagetoid spread here, and it wasn't really difficult to find it, you know? It was very easy to find. But look, the architecture is important, because where is the VT? Look, just apply these rules which I talked to you for the last hour about. The VT has gone, okay? And then we probably are in the territory of malignant melanoma, and then you can see the pagetoid spread quite easily. Then you might say, oh, can it be superficial spreading? Can it be Lentigo maligna? I tend to go to the cells, and if I don't see the proper lacunae of the cells, can you see here? The proper lacunae is absent in this group of cells, and then I tend to call it more of the superficial spreading. At the end of the day, it's still a melanoma, and then you can see that the entire nest here is atypical. No maturation whatsoever toward the center of the nest. The nest really looks very irregular, and this is your paramount, most important feature. These individual atypical cells that you tend to see it in close conjunction with the irregular little nests here, and this is what I will really rely on in order to judge something that this is a malignant melanoma or not, and then I apply the entire criteria. I think to summarize, the 4 cases that might come in the exam are for melanocetic lesion are I'm talking about skin now, will be the spits. The other one will be the pigmented cell nevus of wheat. And in my exam, what happens, you know, we do the exam in April and again in October, and this year it's going to be later because of the corona. And then what it is that in my exam, I had the pigmented cell nevus, the wheat nevus came in April, and I was sitting the exam in October, and it did come again. And the doubt that I had in my mind was, I just saw this case yesterday. Why would it come again? You know, so they tend to do that. So do not use that rule. If the case came 3 or 4 months back, it's not going to come again, then this must be the malignant counterpart. Don't apply that rule, please. Just apply the rules which we've talked about today, and you will be absolutely fine. The other things is that yes, this plastic nevus and the superficial spreading. One other classic scenario that comes in the exam is they give you a short surgical case with melanoma arising in the vulva. And if you are not familiar with melanoma at this region, then you might be caught. So the same rules and the same principles apply, except that you always have the pagetoid spread, which you need to be careful. When you apply the nevus and acral nevi or melanoma at special sites, then just be careful. The pagetoid spread in the lower 1/3 alone is not enough to give you the diagnosis of melanoma. So that's the main difference. The other things which is a very common cases for melanoma for people to fail is the metastasis. And what I saw, and I probably told you before, in about 10 years ago, everyone failed a case of a liver biopsy of melanoma metastasis on a short surgical because it was nests that looks very much like neuroendocrine carcinoma, like carcinoid. And everyone said neuroendocrine carcinoid because of the sites. Liver comes from the upper GI. So, but it was a metastatic melanoma. And this was a very big pitfall, but as we continue, we will go through all these pitfalls. I will finish now, but I just wanted you to be aware that we will be covering in the next hopefully 6 or 8 months, every case that might come in the exam with the pitfalls like this. So don't panic, although I sometimes put the things slower, but when I speed up, I will show you a lot of the entire range as you can see today. So I don't want you to panic, but we need to take our time, and I want you to focus because this will be taken in consideration. There is one question I will answer. No, this is not epidermal consumption. The epidermal consumption, you wanted to see the epidermis as 1 or 2 or 3 layers. If you're still seeing it as 7 or 8 layers, then it isn't. Epidermal consumption can happen and can be a clue. You know, as I told you, this is a superficial spreading example, but not with a confluent nest, but there are some still nests, very confluent seen in part of it. But it's usually here, the dermal component will help you to say it is, because the dermal component in superficial spreading tends to be more epithelioid, while in the Lentigo maligna, in actual fact, if you wanted to know where the desmoplastic melanoma tends to arise from, it tends to arise from the, it tends to arise sometimes from Lentigo maligna melanoma. So which means that the epidermal component in the Lentigo maligna melanoma tends to have a little bit more spindly look into it. But these are all, they are subjects, there will be always exceptions. You know, there is always exceptions to the rule. And the most important thing is to apply approach. And now, what you know from these 3 sessions about melanocytic lesions, that it is definitely not only about symmetry and maturation. There are more into this story. And I stretched into this, but it was a very important stretch because it is the big pitfalls for people who comes from abroad. And these cases, which you can see, are all on the Leeds website. So you just go to the search button, you put an entity, it will open 5 or 6 or 7 cases, sometimes 20, 30. I just chose the cases which I wanted to show you special features and characteristics. But by all means, you should go and see it all on your, and see how it goes. In the future, I will include some of my own scanned collection of slides, but I am just still in the process of building it, and hopefully in 3 or 4 months, I will have more of my own collections as well to show you into this. Next time, we will we will tackle the thyroid case that you have in the mock. And then we will be talking a lot about the thyroid problems that comes in the exam and how we will get around it. So the only request that I wanted to know is that next Monday for me might still coincide with the Eid, and therefore I wonder if we can, we have one of two options. We can do this Wednesday instead of Monday, and then and then we go back to Mondays after that, instead of just to avoid missing a session, because I might be celebrating the Eid, as I told you, till Monday. So Monday might be tricky. So just discuss it among yourselves and send us and let us know if Wednesday between 6 and 7 will be okay, and we will discuss the thyroid glands, the thyroid gland case. Again, I know a lot of you might feel bored because the sessions takes long on discussion of certain cases, but believe me, this will be helpful. And it's a different format. You can try all formats, but I will never ever give you an entire specialty in 1 hour. I can do that, but I will never do that. So don't get dragged into this sort of teaching, because these are more confusing than useful. Thanks you again, guys, for tuning in, and we shall catch up on Wednesday, hopefully, if everyone is in agreement. Thank you.